My name is Amara and I'm a UK resident doctor, and here are 5 things I learned working as a doctor in geriatrics that if you have grandparents, parents, or you're over 65 are sure to improve your physical health. Falls are actually way more dangerous than people realise, and if a patient requires hospitalisation due to a fall, they have a 33% risk of dying over the next year. This can be due to complications arising from any surgeries they might require, hospital-acquired infections, and even blood clots from prolonged periods of immobility in hospital. In fact, when I was at med school, they taught us that every cause has a fall, and it is up to the medical team to identify what that cause is. Broadly speaking, the causes of falls can be categorized into physical health conditions and environmental hazards. Now, one of the most common causes of falls that I saw in the elderly was something called postural hypotension. Now, when we stand up, because of the force of gravity, blood is pulled towards our legs away from our brain. Now, thankfully, our bodies have something called the baroreceptor reflex, which means that our blood vessels contract, meaning less blood can be pulled away from our brain and towards our legs. Now, unfortunately, this reflex dramatically deteriorates as we get older. Therefore, unfortunately, in some elderly people, when they stand up from sitting or lying down too quickly, this can cause their blood pressure to drop, leading them to feel lightheaded and therefore causing a fall. Other common causes of falls can be things like UTIs and chest infections, certain medications that can lead to sedation or low blood pressure, or even in fact too many medications, and things like vision problems. And of course, environmental hazards can lead to falls too, for example having pets, other obstacles, or for example stairs in the house. But the good news is there are many things we can do to reduce our risk of falls. For example, regular eye checkups, strength building exercises like Tai Chi or resistance training, having a doctor or a community pharmacist carry out a medications review, talking to physiotherapists that can recommend certain mobility aids, and of course occupational therapists that can do home assessments and make recommendations as to how to make the home a safer place in order to reduce your risk of falls. Did you know that most elderly patients do not recover from long periods of immobility and in fact merely adapt to their new lower level of fitness? Every week spent in bed leads to a 10% loss in muscle mass, which can take up to 3 times longer to rebuild. In fact, bed rest actually mimics the environment that astronauts are exposed to when they go to space and are in zero gravity. Now, these are some of the risks that are associated with prolonged periods of bed rest: blood clots in the limbs and lungs, muscle atrophy and an increased risk of fractures, worsening postural hypertension because of further deterioration that happens to the baroreceptor reflex that we mentioned previously when we spend long periods of time lying down, constipation and reduced oxygen consumption capacity. Now, in my last shift at the geriatric admissions unit, there was actually a patient who was being kept in bed while we were finding the source of his infection. After clerking him with the consultant, we actually found out that previous to this hospital admission, he was actually independently mobile, but the nursing staff didn't know this, so he was being kept in bed. So it's very important that if you're a family member or a loved one and your parent goes into hospital, that you speak to the nursing staff or physiotherapist and ask them what the mobility plan is, and encourage where possible for the patient to get out of bed. Now, before working in geriatrics, I thought that forgetfulness was just a natural part of aging, but this isn't entirely true. I've seen many patients come in with infections such as UTIs and pneumonia, and they become very disorientated. They don't know where they are, what the date is. They seem very sleepy and can sometimes even become very aggressive. Now, this is because new onset confusion that occurs over a short period of time, for example from a couple of days to a couple of weeks, can actually be due to delirium, which is a practically reversible physical health symptom. Now, delirium can actually affect up to 50% of hospitalized patients and unfortunately can persist even once the patient is better. On the other hand, very slow, gradual memory loss that occurs from 6 months to several years that particularly affects a patient's short-term memory can be a sign of dementia. Now, as a doctor working in geriatrics, I saw a wide range of presentations for dementia depending on what stage of dementia they were at. One of the more basic symptoms that I saw was sort of word finding difficulties. For example, if you point to a phone case on the table and you ask them, can you name what that is? They may struggle to remember the word for phone case and spend quite a while searching for that word. Also, short-term memory is particularly affected. For example, even though patients can talk about events that happened a long time ago in great detail, they may end up repeating themselves simply because they don't remember that they just said something, or when it comes to doing a task, do that task over and over again. This may lead to difficulties completing everyday tasks, for example, following a recipe, because that short-term memory is impaired. And unfortunately, I also saw many patients who were experiencing the later stages of dementia. For example, some patients would no longer be able to recognize food, no longer be able to recognize when they were hungry and that the food was what they needed in order to sustain life. So they would even start playing with their food because they didn't recognize what was in front of them. I also saw patients become non-verbal and lose the ability to communicate with the loved ones around them, and even experience seizures due to their dementia. Now, there are many different types of dementias which are all related to the symptoms that manifest and where in the brain they occur. So if you are concerned that a loved one or yourself has dementia, then please do get in touch with a doctor so you can get a prompt evaluation and support. Now, unfortunately, one of the main struggles that we have in geriatric medicine is discharges. There were many patients whose discharge was delayed because there were no available nursing or care homes, or because a home assessment was yet to be carried out at home to make sure that it was safe for the patient to be discharged to. Now, although hospitals are essential in treating and managing physical health conditions, they're not the safest place for elderly patients. Unfortunately, I met many patients who were medically safe for discharge, but because there was a delay somewhere along that pathway, they actually contracted a hospital-acquired infection such as pneumonia, which complicated and even further delayed their discharge home. Additionally, there were sometimes disagreements between the medical team and relatives as to what it means by being medically safe for discharge. Sometimes patients were discharged when they still had an ongoing active infection, or where their blood sugars were a little deranged, or they were still a bit confused. Now, this is because for the medical team, the risks of staying in hospital outweighed the benefits of, for example, finishing the antibiotic course in hospital or waiting for the delirium to subside, meaning that these conditions are most likely best treated in the community. Not only do hospitals pose a risk of infections and, as we mentioned before, reduce patients' mobility, but also they will definitely prolong and cause patients to be confused. This is because you don't have loved ones around, you definitely don't get a good night's sleep with all the beeping and the other agitated patients on the ward, the food isn't that great, and it's a completely unfamiliar place. That being said, there are of course many instances where the risks of not going to hospital far outweigh the benefits. But if you are concerned that a relative is being discharged too soon, then please speak to your medical team about this. Conversations about do not attempt CPR or DNA CPR are very difficult for both the medical team and the patients and their relatives. People often think that this is a sign of the medical team giving up on patients, but let's look at the facts. A cardiac arrest occurs when a patient no longer has a palpable pulse and stops breathing, and this is usually treated with chest compressions, oxygen, and some medications, and sometimes defibrillation. Did you know that only 23% of patients that receive CPR actually survive to discharge? Now, this rate is far reduced when you have patients that are frail and have many comorbidities. Now, some research suggests that patients with a clinical frailty score of 5 and above are very unlikely to survive CPR, and if they do, will require ICU admission, although ICU may not deem them as a suitable candidate to receive ICU treatment, will experience significant neurological and physical complications and even organ failure. All of this ultimately leads to a reduced quality of life. Now, what is a clinical frailty score of 5? Now, elderly patients are unable to do their housework, unable to prepare meals, and get around places without assistance would be deemed as having a clinical frailty score of 5. However, it is very important to note that even if a patient does not receive CPR, they may still receive full active treatment. So if they go to hospital, they will still receive, for example, IV fluids, antibiotics, and ward-based care. It is so important that these conversations about CPR are had in non-urgent settings, not when CPR is required. Now, in the UK, we now use these things called respect forms, which talk about way more topics than just CPR, including the patient's wishes and what they wouldn't like when it comes to their treatment. Please speak to your doctor for more information about this. Now, through working geriatrics, I've learned about many things that can improve the quality of life of elderly patients that we might not think about. For example, talking about DNA CPR and their ceilings of treatment, encouraging mobility, seeking help as early as possible, and understanding that falls aren't something that are benign and that should get looked into. Now, something that I learned through geriatrics that I didn't realise before is how much can be done to improve the quality of life of an elderly patient. For example, an elderly patient that, let's say, has really bad arthritis or has recently had knee surgery might think that bed rest is the only thing that they can do. But for example, occupational health therapists, physiotherapists have so many mobility aids and so many things that can help them improve their mobility, to help them get out of bed, to help them sit up on a chair, which has so many health benefits. I also didn't realize how small things, for example, encouraging elderly patients to be mobile, encouraging them to do exercise, especially ones that build strength, like Tai Chi, a good diet, supplements when required, staying hydrated, how important these can be to improving long-term health outcomes. So don't forget to like this video if you learned something new, share it with someone who you think would find it helpful, and as always, subscribe to see more.